share your slides and while I go on with your introduction. So Dr. Hart is an associate professor of medicine at in the Division of Gastroenterology, Hepatology, and Nutrition at the Ohio State University Wexner Medical Center. He completed training at Mayo Clinic in Rochester, including training in Medical Pancreatology Fellowship. Dr. Hart is a counselor for the IAP and associate editor for Pancreatology. He has published extensively regarding the management and long-term outcomes of autoimmune pancreatitis, pancreatogenic diabetes secondary to chronic pancreatitis, and pancreas cancer and EPI. We have a second speaker. It will be a joint presentation. The second speaker is Dr. Kristen Roberts. Dr. Kristen Roberts is a registered dietitian, nutritionist with over 15 years clinical experience in gastrointestinal failure, gut rehabilitation, and nutritional support. She holds a joint appointment with the Division of Gastroenterology, Hepatology, and Nutrition and the School of Health and Rehabilitation Sciences at OSU. She is a fellow of the Academy of Nutrition and Dietetics of the American Society for Parenteral and Enteral Nutrition. So thank you, Dr. Hart, and thank you, Dr. Roberts, and looking forward to your presentation.
Great. Well, thank you for having us today. And as mentioned, I'm Kristen Roberts, and I'm going to be starting off our lecture today talking about nutritional management in acute pancreatitis. And then Dr. Hart will be following up with the nutritional management in chronic pancreatitis. And neither of us have any disclosures related to this talk. So from the dietitian perspective, understanding the nutritional status of these patients when they are admitted into the hospital is really important because this is the information that we utilize to determine the nutritional plan of care for these patients. So those patients that are admitted into the ICU with moderate to severe acute pancreatitis are automatically associated to be at high nutritional risk, and they'll be seen by a dietitian within 24 hours of that admission. Whereas those patients with mild disease that are admitted to regular nursing floor will be assessed for nutritional risk by a clinical, by a member of the clinical team, and then a dietitian consult as needed. So I bring this up because there are lots of different ways to determine nutritional risk, but one of the factors that we like to highlight is that body mass index or body weight is not a surrogate for malnutrition. We could see both under and over nutrition being associated with pancreatitis. Another nutritional concern that we think about is that these patients, when they're admitted to the hospital, have a high degree of weight loss after that hospital admission. And we know when there's a big degree of body weight loss, that's associated with a loss of lean body mass. And that can be associated with increased infectious complications and higher rates of mortality. So these are the outcomes that we look at for our nutrition interventions, hopefully trying to minimize. We also know with this patient population that some etiologies can be related to alcohol abuse, and these patients may or may not be at an increased risk for refeeding syndrome due to poor oral intake prior to that hospital admission. And so there is a risk of thiamine deficiency, and this is why you'll see empiric treatment in many ICUs with anywhere from like 100 to 300 milligrams, either given orally or intravenously for up to the first week of hospital admission. And that can really help to reduce some of the consequences of the thiamine deficiency that you can see listed here. So we do have guidelines, and many of you are likely familiar with these guidelines that either are specifically for pancreatitis or have a component of them that is dedicated to this disease. And there's lots of similarities with these guidelines. One, in fact, is that many of these authors are calling for more studies, prospective trials, randomized clinical control trials, where we're seeing various nutrition interventions studying these outcomes. And because we're lacking a lot of this, it leads us to see that in most of these guidelines, we see some type of algorithm that looks like this, where a patient is admitted into the hospital, they're stratified by disease severity, where those mild cases are admitted to the regular nursing floor and usually started on an oral diet. Where those moderate to severe cases are admitted into the ICU, a dietitian, again, is seeing them hopefully within 24 hours of that hospital admission and initiating enteral nutrition. And in those patients that are not tolerating enteral nutrition, then we have to make that decision about when to use parenteral nutrition and when is it appropriate to also minimize those risks that are associated with that therapy. But when I see these algorithms, I think that there's a couple of points that I'd just like to spend some time highlighting today. One is, what type of diet should we be starting those patients on with mild disease on the regular nursing floor? And one that I think is really important is really understanding how to determine tolerance to enteral nutrition, because this could be the key for us preventing the use of parenteral nutrition, and again, minimizing those risks associated with that therapy. And then again, just kind of touching on when should we be using this, if at all, in this patient population. So I'm going to focus on using the ASPEN guidelines. And the reason for that is that these are the guidelines that many critical care dietitians are utilizing to help them make decisions on the use of nutrition support in ICUs. So we know those patients that have mild disease usually do not require nutrition support unless they've had inadequate oral intake for over a week. We also know, and all of the guidelines suggest this, that a solid diet is preferred over a clear liquid diet. And so what this forest plot is showing you is that there is a decreased hospital length of stay when we initiate these patients on a solid diet compared to a clear liquid diet. Similar analyses have also shown that there's no difference in abdominal discomfort or nausea and vomiting between these two. So again, highlighting that preference for starting these patients on a solid diet. When we see the cases of moderate to severe acute pancreatitis, this is when all of the guidelines are suggesting that we need to get started on enteral nutrition. And ASPEN specifically states that we need to be advancing to goal calories within that first 2 days of hospital admission, and using a standard polymeric formula is appropriate. And when we achieve early enteral nutrition, we can see reduced infectious complications and mortality associated with this. However, this is a big challenge in the ICU of getting these patients to goal calories this quickly. So in other patient populations, we're starting to see the use of volume-based feeding protocols, where it allows the nurse to titrate the infusion rate of these enteral nutrition prescriptions to get the full volume in at the end of an 8-hour nursing shift. And this could be an area that we look into investigating more with acute pancreatitis to help us reach those goals. But a polymeric formula is an intact macronutrient formula that usually contains anywhere from 1 to 1.5 calories per ml. And we see polymeric formulas that are manufactured both with and without fiber. So fiber can be a challenging nutrient in enteral nutrition. It could have, beneficial effects, particularly for those patients that have some diarrhea. And we can see either some fermentable fibers that are added to those polymeric formulas or are used on the outside and supplemented in divided doses can be beneficial. But this also can cause some GI upset as well, and some abdominal discomfort. So again, that monitoring piece is really important to help us determine that appropriate formula. There's also emerging literature that's suggesting the role for these fermentable fibers, possibly in addition to probiotics, and seeing potentially some benefit in severe acute pancreatitis. And I think this is going to be a really interesting area to see what future research shows, so that we can understand a little bit more about the strands and the doses that may be beneficial. So the monitoring piece, I think, is really important, again, because it helps us to determine if we're going to achieve that goal of meeting 100% of the patient's calorie requirements within that 48 hours, or if we're going to need to progress and use either an NJ feeding or parenteral nutrition. And so the dietitian does do a nutrition-focused physical exam on these patients, which includes an abdominal assessment to help us determine tolerance. But one of the bigger challenges I see as well is that typically in an ICU, we use predictive equations to determine somebody's calorie requirements. And it's well documented that these are not the most accurate tools when we compare them to indirect calorimetry. And historically, indirect calorimetry just hasn't been available to us in most hospital settings, and that still is the case. However, the new GE vents contain an indirect calorimeter. So if you have expertise in your hospital with a respiratory therapist and a dietitian that's used to seeing this output data, this could be an option. And there are also individual units that are available as well for purchase that can really help us determine the appropriate caloric dose for these patients, and again, get us to that goal and hopefully prevent that loss, that body weight loss that we see after hospitalization that's associated with that loss of lean body mass and function. So how do we improve tolerance to enteral nutrition? It's very clear in an ICU that continuous infusions are superior to bolus feeds, and that's with almost all diagnoses in an ICU. But pharmacotherapy can be utilized as well, and really looking at these patients that have signs of malabsorption or diarrhea and getting medications on board to help support that digestion and absorption process when it's applicable can be helpful. And also ASPEN guidelines recommends that we avoid using gastric residual volumes as a measurement of enteral nutrition tolerance. And although this is still part of a lot of ICU protocols, again, there's a lot of effort in trying to minimize the use of these for determining tolerance, because we see abrupt discontinuation of enteral nutrition when we start measuring these. And so ASPEN guidelines specifically states, let's try not to hold it unless these volumes are over 500 mLs. So the last question that I'm tackling here is, the selection of enteral nutrition over parenteral nutrition. And this is very clear data as well. And it's documented in all of our guidelines that we should be selecting enteral nutrition over parenteral nutrition for a variety of reasons. This forest plot is showing improved mortality and improvements in infectious complications with the use of enteral nutrition. However, what I want to highlight is that there are patients that we struggle to get to their goal calories with enteral nutrition for a variety of different reasons in these severe cases. And those patients where either enteral nutrition is not feasible or we're unable to improve tolerance after a week and a half, we should be considering supplemental parenteral nutrition to help meet nutritional requirements and again, prevent that weight loss and that lean body mass that's associated with that. So in summary, oral diet is sufficient in mild acute pancreatitis. And again, early enteral nutrition is really our goal in those moderate to severe cases. Really pushing effort to monitor tolerance and optimize that nutrition prescription is really important to prevent us from having to utilize parenteral nutrition. And again, getting that reduction in infectious complications and mortality. And more research is needed to really understand the role of the gut microbiota and how we can alter our nutrition prescriptions to hopefully modulate the severity of this disease. Thank you.
Great, thanks, Kristen. My name is Phil Hart, and I'll be spending the next 10 minutes or so discussing the other aspect of nutrition in the setting of pancreatitis, specifically related to chronic pancreatitis. And we don't have the time to do all of the comparisons and contrasts, but I think that there'll be a number of really striking differences as it relates to the evidence base for and the approach to managing patients with chronic pancreatitis. And as would be expected, this will primarily focus on outpatient management of chronic pancreatitis. And so in the next 10 minutes or so, I want to talk about why does this matter? Why should we be giving any attention to this topic at all in the setting of chronic pancreatitis, understanding that there are many other more pressing issues, as Dr. Singh is going to get to talk about later on, including abdominal pain. I'm going to talk a little bit about the evidence base or lack thereof, and outline a few of what I view to be the key questions that are outstanding. And then to discuss with a little bit more specificity and just provide some suggested guidance related to clinical management of this. Next slide, please. So why is it important to consider nutrition in chronic pancreatitis? Well, the reason is that there's this complicated interplay between risk factors for and complications of chronic pancreatitis that can add together and perhaps even synergistically work together to negatively impact a patient's nutritional status. And the shared risk factors for both chronic pancreatitis as well as a poor nutritional status include cigarette smoking, heavy alcohol use is well known, But then also when we think about some of the symptoms and complications that are commonly seen in patients with pancreatitis, such as abdominal pain, diabetes, exocrine pancreatic insufficiency, it's very easy to see how this is ends up being a common problem for patients. Although less common, there are other disease-related complications that we have to really take into consideration. Things like pseudocysts, which is shown in the picture here to the right of the slide. You can easily see how the cyst compresses anteriorly on the gastric lumen, but also things like recurrent episodes of acute pancreatitis rather, and the occasional patient who may experience gastric outlet obstruction. Next slide. So there's a combination of anatomic and metabolic factors that, again, can interact in a really complicated manner to contribute to some of the nutritional abnormalities that we see. And in contrast to acute pancreatitis, one of the things that makes this topic a little more difficult in the setting of chronic pancreatitis is the reality that these types of complications are more insidious. They're less dramatic than what we're observing in the inpatient setting. And they're also they haven't been directly associated with key clinical outcomes. For example, in the acute pancreatitis literature, we have concerns related to associations with Lincoln-Say and mortality. Nevertheless, we as gastroenterologists are commonly trained to identify things like diabetes or overt steatorrhea, but there's often not as much attention paid to other things, which again can be more stealthy and difficult to identify unless there's an index of clinical suspicion. These would be things like micronutrient deficiencies, and particularly vitamin D and vitamin K deficiencies are commonly observed when checked, but other things as well, including having a low body mass index or being underweight, as well as the association with sarcopenia, which has been more recently identified. Next slide. Well, one of the challenges that we face when we're talking about and thinking about the nutritional management of patients with chronic pancreatitis is that we really don't have a very sturdy evidence base to work from. There's additional insights and rigorous studies that are needed really across the board in this topic. And just to outline a few different aspects of this, the first is that even though we do have a general sense that these are common findings, we still need more detailed studies related to the prevalence of these nutritional sequelae, and specifically to try to identify what contributing factors are related to what specific nutritional sequelae, if that's even possible to dissect that. But also thinking about things from a patient perspective, we really don't have a good understanding of the patient's viewpoint on this. For example, what are the sources that they're going to look for guidance? What type of guidance are they even being provided, considering there's not really a sturdy evidence base? And also, what are the patient's priorities as it relates to nutrition? And then other things, other questions relate to what do we do? How do we try to either prevent or reduce some of these nutritional sequelae using either things like dietary modifications, nutrient or vitamin supplementation, and or pancreatic enzyme replacement therapy. And the last one, even though we do have quite a bit of studies related to PERT, there's still many unanswered questions related to the optimal approach. For example, when should we start this? What dose should we use? And how should we be titrating enzymes for an individual patient and confirming that they're on appropriate dosing? Next slide. So with the lack of prescriptive evidence to follow, I'd like to propose a number of goals to consider when we're thinking about the nutritional management of patients with chronic pancreatitis. The first, as I alluded to before, is to identify and ideally be able to also address any contributing risk factors, such as cigarette smoking, alcohol use. And I also list on here food insecurity, which relates to a patient's financial means and ability to access food on a consistent basis. This is something that is increasingly gaining attention in the dietetics literature. It's starting to spill over into the gastroenterology literature, but we really don't have a great sense of this as it relates to chronic pancreatitis. The second is to manage symptoms that might interfere with dietary intake. And as gastroenterologists, from that perspective, again, this is where we are most prone to directing our attention specifically as it relates to abdominal pain and considering, opioid, non-opioid analgesia, endoscopic options, and surgical options. But it's easy to forget and to consider other symptoms as well that might be contributing. Next is to screen for and treat chronic pancreatitis-related complications and nutritional sequelae, which I previewed before. And then lastly, to assess the potential need for nutrition support, be it enteral nutrition or in rare cases, parenteral nutrition. Next slide. Well, although there is not a lot of original data that we have to work from, fortunately, this is being recognized as an area that's needing attention. And over the last 5 years, there have been a series of multidisciplinary groups and societies that have put forth guidelines, primarily from an expert opinion-based perspective that we have to review and to at least begin to work from. Next slide. But as you can see in these excerpts from the ACG clinical guidelines for chronic pancreatitis, these guidelines sometimes fail to provide us with the specificity that we need to be able to make patient-level decisions. So for example, in the first bullet, the guideline authors suggest the use of PERT in patients with chronic pancreatitis and exocrine pancreatic insufficiency, although they stop there to provide any further guidance. Similarly, there's recommendations for periodic evaluation of malnutrition, but without any additional specificity. And in the defense of the authors of these documents, I think what they are trying to do is to not overstate what is not explicitly demonstrated in the literature. At the same time, though, as healthcare providers meeting with patients in the office, we still need to make decisions and provide recommendations. Next slide. So in the last couple minutes here, I'd like to describe a clinical approach that we use at our institution in combination with dietitians like Dr. Roberts. But I'd also like to disclose this is not the way. This is a way. Again, speaking from the reality that we don't have prescriptive evidence-based guidance in terms of what to do. But to begin, all of our patients in the pancreas clinic, including those who don't have chronic pancreatitis, are systematically screened using the malnutrition screening tool by our nursing team. This is employed as if it was a vital sign. The MST, for those who aren't familiar, is a two-part brief questionnaire that's related to unexplained weight loss and difficulties with oral intake. So it provides a very crude measure to highlight and emphasize those patients where we may need to spend and provide more attention to nutrition during the visit. The second is that we offer all of our patients with chronic pancreatitis access to complete an online food frequency questionnaire. And this is a much more detailed assessment of dietary intake patterns, which you can understand can be more or less useful in different patient scenarios. The next is that we recommend annual screening for micronutrient deficiencies for all of our patients with chronic pancreatitis, independent of any risk factors, symptoms, or other. As you can see here, this focuses on the fat-soluble vitamins, but also on vitamins B12, zinc, particularly for those with ongoing and active alcohol use, and then also a CRP level to help us to be able to accurately interpret those values. Next slide. Next, we have perpetual assessments for any symptoms, both potentially representing either mild or severe exocrine pancreatic insufficiency, with periodic use of fecal elastase, particularly if we're working to establish a diagnosis of EPI in a patient with non-severe symptoms. We recommend annual screening for diabetes, typically with a hemoglobin A1C, since most patients come to the office in a non-fasting state. And then lastly, we offer baseline screening for osteoporosis for all patients. Again, this is independent of age, sex, and other risk factors for metabolic bone disease. And then lastly, as it relates to knowing what to do and considering all of the different nuances that come up as it relates to handling micronutrient deficiencies or nutritional assessments, we have a very low threshold in our group to formally involve our dietetics team. Next slide. So in summary, I've shared that nutritional complications are common in patients with chronic pancreatitis. And again, there are multiple contributing factors to this observation. One of the challenges we face, though, is that the evidence base to provide recommendations for us related to how we go about screening and managing these complications is limited, and something that warrants much additional dedicated attention. And lastly, at least in the interim, as we're awaiting additional evidence, we propose and suggest that individuals consider being systematic in their approach to screening for these commonly observed abnormalities, and when possible, realizing that there are a lot of institutional differences and other factors to be considered, including a multidisciplinary team, particularly including dietitians and endocrinologists. Next slide. So with that, we'd like to thank everybody for joining today and for your attention. We have a few minutes here for questions, and we'll ask the moderator to guide us through the questions. But if we run out of time, or if there are any questions that come up after the fact, please feel free to contact either myself or Dr. Roberts directly at the email addresses shown here. So thanks again.
Thank you, Dr. Roberts, and thank you, Dr. Hart. That was very, very informative, and especially your practical points on the clinical approach of how you do things there. Reminder to the audience, please feel free to put your questions in the chat box, and we have only a few more minutes, but we can also discuss later. So while we wait for questions, Dr. Roberts and Dr. Hart, a couple of questions from my side. And Dr. Roberts, you have emphasized on the importance of early enteral nutrition. At least 7 randomized controlled trials have shown that early enteral nutrition is safe and improves outcomes. On the practical side, when do you exactly start early enteral nutrition, say someone with mild pancreatitis, and what markers do you say, or what signs do you see to decide this patient is ready for early nutrition?
Yeah, that's a great question. So usually we actually at OSU will have the medical team actually get the enteral nutrition started while they're waiting for that 24 hours for the dietitian consult. As long as the patients are hemodynamically stable, and usually during that fluid resuscitation period is when we go ahead and get started. We do start with a trophic feed, so it's usually just 10, 15 cc's an hour to make sure that these patients are doing okay. And then by that time, we can get the dietitian consult in there and start advancing that tube feeding up to goal rate. So that's currently how we're approaching it here at OSU.
So do you allow oral nutrition also, or do you always go for tube feeds?
It's very patient specific. I think if the patients are able to consume anything by mouth, then we do allow them to consume food. And in those situations, we may not even go right to getting the enteral nutrition. We can get oral supplements on board and give them that way instead of having to place the tube. But in those cases that we're getting more severe disease, these patients are usually started with an NG tube right away and getting started on enteral nutrition. And we're advancing the tube into the jejunum only in those cases where we're seeing intolerance or we're more concerned about an aspiration risk.
Thank you so much, Dr. Roberts. And we'll take one quick question before we go to Dr. Singh, maybe. Dr. Hart, you have emphasized on the importance of micronutrients in these patients with chronic pancreatitis. Do you think there is any role for some of these micronutrients with antioxidant properties in reducing pain in chronic pancreatitis?
Good question. So the question is whether or not, say, for example, in the context of a patient with painful chronic pancreatitis or chronic pain syndrome, should we be checking micronutrients as a guide for who may benefit or potentially predict who may benefit more favorably from antioxidant supplementation? Is that?
That's right. Mm-hmm.
Do I understand that right? Yeah, that's a good question. I don't have a great answer to that, to be honest. I mean, in the randomized controlled studies that have looked at antioxidant therapy as an intervention, I don't believe it was universal, supplementation, as you know, independent of their baseline status of those micronutrients. Again, with mixed results in the studies, and I guess, to be honest, that would be, in my mind, the primary data set that would really help to more clearly answer your question. In clinical practice, no, I don't use them for that purpose. It's more related to trying to pinpoint those that are predicted to be low, and trying to supplement those in that way.
Thank you, Dr. Hart. Like, still some more things to be clarified on those lines, maybe. Dr. Singh, please feel free to share your slides. The next speaker is Dr. Vikesh Singh. Dr. Singh will be speaking on non-opioid management of abdominal pain caused by chronic pancreatitis. Dr. Vikesh Singh is an associate professor of medicine at Johns Hopkins Hospital. He received his training from Brigham and Women's and Johns